Good morning. In this session, we are going to review the most important items or topics that we have covered in the circulatory system, and this will be your final revision before semester one test. I'll go over the slides and I'll be telling you rapidly what type of questions might be seen on the exam related to the slide. Of course, concerning this slide, I'll not be writing a lot because we have covered this several times. And in order to save time so that I could go over most of the concepts, in this slide, what's most important is, first of all, to know the components of the lymphatic system. So you first have to know what the circulatory system consists of. So you have to know that the circulatory system consists of the lymphatic system and the cardiovascular system. So the lymphatic system is part of the circulatory system, but not a part of the cardiovascular system, although they are connected. The second question that you might encounter on the test related to this slide is the components of the lymphatic system itself, the components of the lymphatic system. So what does the lymphatic system consist of? It consists of lymphatic organs, it consists of lymphatic vessels and lymph nodes, or we would say more accurately that it consists of lymphatic organs, lymph nodes, and in between them, we have the lymphatic vessels. The third question that you might see related to that slide is to enumerate the lymphatic organs or list the names of the lymphatic organs, in which case you would mention them all. In order not to forget anything, you start by saying the lymph nodes, because the lymph nodes are present everywhere in the body. You wouldn't enumerate the lymph nodes. You wouldn't say, for example, cervical lymph nodes, thoracic lymph nodes, abdominal lymph nodes, but just lymph nodes. In addition to the lymph nodes, here you have the tonsils, and in the nose you have the adenoids, and then in the neck you have the thymus, and then in the abdomen you have the spleen, and in the small intestine, in the abdomen again, and in the appendix you have Peyer's patches, and then you have the lymphatic tissue that is present in the bone marrow. Of course, if you have a question related to that slide, it would be a direct, straightforward question about the need for a circulatory system, or justify the need for a circulatory system, in which case I would like you to focus on the deep cells. So you talk about complex organisms. Complex organisms have deep cells, and simple diffusion cannot provide the deep cells with oxygen and nutrients. And this is in contradistinction to unicellular organisms that consist of one cell that is surrounded by the medium containing oxygen and nutrients all around. And then you might be asked, of course, about the anatomical location of the heart. So you have to start by saying that it lies in the thoracic cavity. It lies in between the two lungs. The base of the heart lies above the diaphragm, and the heart itself lies in front of the esophagus. And of course, the whole heart is enclosed in the thoracic cavity. And here, of course, you can see the anatomical location of the heart. I might also ask you, for example, about the large vessels that are connected to the upper border of the heart. So or the large vessels in general that are connected to the heart. So you would be talking about the superior vena cava, the inferior vena cava, the aorta, the pulmonary artery, and the pulmonary veins. Of course, a chest X-ray would not only allow you to visualize the lungs, but also to visualize the heart. And this is useful because in some cases, in some clinical cases, like in left ventricular failure, for example, there will be back pressure on the lungs and congestion of the lungs. So it is important and useful to visualize both organs at the same time, the heart and the lung. Of course, if you are to be asked about the normal heart X-ray, you would first be asked about the cardiothoracic ratio and how to measure the cardiothoracic ratio and what is the significance of the cardiothoracic ratio. Of course, the cardiothoracic ratio is the ratio between the width of the heart, the maximum width of the heart, and the maximum width of the chest cavity. But because the maximum or the most bulging points of the heart are not at the same level, then the way you do it, I'll remind you of this, I'll be reminding you of this. The way you do it is to divide the heart into two, to select the most prominent point on the left border of the heart, the most prominent point on the right border of the heart. And as you see, they're not necessarily on, they're mostly not on the same horizontal level. And therefore, the next step is to draw a horizontal, of course, with a ruler. And in order to make sure that this is the horizontal, then this angle should be 90 and that angle should be 90. And then you call this A, for example, and you call the other line segment B. You add A and B, and by having added A and B, you have reached the width of the heart at its maximum bulging. And here we have the most prominent points of the chest cavity. And because the most prominent points are at the same level, then we draw a transverse line and we call it C. And then you divide the sum that is A plus B divided by C. And this sum should be equal to or less than 50%. Okay? What's the clinical significance of the cardiothoracic ratio? Of course, the clinical significance of the cardiothoracic ratio is to determine whether or to decide whether the heart is enlarged or not. If it is less than 50 or equal to 50, then this is normal. If it is more than 50, then you have one of two reasons. Either cardiomegaly, meaning that the heart itself is enlarged, like, for example, in right ventricular failure or left ventricular failure, or in cardiomyopathy, or that the heart is normal in size, but there is fluid accumulation around the heart, meaning that you have a case of pericardial effusion. And it is interesting to know that the heart in pericardial effusion can be more or less looking like this, looking like a flask-shaped heart that is, of course, having a cardiothoracic ratio more than 50. I can tell you that I wouldn't be asking you about the lobes of the lungs because we're going to discuss this in detail in the respiratory system. In this slide, what is most important is to know the level of the diaphragm. But before knowing the level of the diaphragm, you might be asked about the importance of the sternum in a local examination of the heart. The question might be as general as this, or it might be more specific. For example, I might ask you about the significance or the importance of that line. That line represents a Lewis angle or the sternal angle, and its importance is that it helps you determine the location of the second intercostal space to the right, which is the aortic area, and the second intercostal space to the left, which is the pulmonary area. So the importance of the manubrium sterni, not the manubrium sterni. The manubrium sterni is the upper part of the sternum. The body of the sternum is the lower part, the tapered part, and in between them we have the angle. Okay. And we use this angle in order to determine the second intercostal space to the right, which is the aortic area, and the second intercostal space to the left, which is the pulmonary area. The ribs and the clavicle also help us determine the apex, because on the left side, if you take a point at the middle of the clavicle and you drop a perpendicular like this, then this is the mid-clavicular line. And if you count the spaces, this is between the first rib and the second rib, this is space number 1. Space number 2, space number 3, space number 4, and space number 5. So the apex is present here. The apex of the heart is located in the 5th intercostal space, mid-clavicular line. If you go a bit to the left, at the left sternal edge, but still in the 5th intercostal space, you will have the mitral area. So meanwhile, we have reviewed the auscultatory area. So here you have the aortic area to the right, you have the pulmonary area, second intercostal space to the left, 5th intercostal space, mid-clavicular line is the apex, and 5th intercostal space, left sternal edge is the mitral area. Notice, of course, that when you listen to the aortic area and the pulmonary area, you listen close to the sternal edge. It's also important to know, to count the ribs correctly, because this helps you locate or helps you know the position of the diaphragm. And why is it important to know the position of the diaphragm? It is important when you are doing a chest X-ray and a heart X-ray, or a chest X-ray to visualize the heart, and specifically to know the size of the heart. So you first have to standardize the position of the diaphragm. So the patient should be in deep inspiration, and our target is to have the diaphragm at the level of the 5th to 6th ribs anteriorly, or the 8th to 10th ribs posteriorly, or between the 8th and 10th. And I highly recommend that you use the anterior ribs, because it's much easier for you to locate them. Another question that is related to this slide is how can you make sure that the patient is positioned properly for visualizing the heart? So in such a case, if I leave the question as general as this, so you would say positioning includes deep inspiration and a symmetry of the clavicle. So we have talked about deep inspiration, which implies a certain level of the diaphragm, anteriorly and posteriorly. And you also have to say that the patient should be symmetric, meaning that how can I know that the picture is, or the patient is standing in a symmetric way in front of the device? That if you measure the length of the length that you can see, the visualized length of the clavicle to the right and the visualized length of the clavicle to the left, they would be equal to each other. Of course, we said that if the heart is, if the cardiothoracic ratio is more than 50, then this means one of two conditions. And one of them is pericardial effusion. So you have to know, first of all, what the pericardium is, what pericarditis is, what pericardial effusion is, and the causes. So the pericardium is a double membrane that surrounds the heart and protects it, and that has minimal fluid in between the visceral layer, the inner layer that is adherent to the heart, and the outer layer. So usually we have two layers. They are firm, they are tough, but they are very tough to protect, but meanwhile they are very smooth in order to prevent friction. And moreover, we have a minimal, normal amount of fluid that is present in between the two layers in order to prevent friction. So pericarditis just means inflammation in the pericardium. And that inflammation is usually viral pericarditis following an attack of, for example, viral influenza or maybe COVID-19 or any kind of viruses. But it might rarely be bacterial pericarditis, especially in tuberculosis, tuberculous pericarditis, which is a very serious condition. It might be autoimmune, just like your immune system attacks the valves of the heart and the connective tissues in the joint, it might also attack the connective tissue, which is the pericardium, because autoimmune diseases usually attack the connective tissues in the body, and that's why they're systemic diseases, they're widespread, and we used to call them connective tissue diseases. Rheumatic fever, lupus, systemic lupus, rheumatoid arthritis, all this, we used to call them connective tissue diseases. And there remains pericardial effusion. Secondary to pericarditis, there is exudation, excessive exudation, and abnormal accumulation of fluid. But inshallah, during our study on the respiratory system, we will find out that pericardial effusion, just like pleural effusion around the lung, might also be due to transsudation, meaning that there is increased water pressure, for example, because of heart failure. We forgot to say one important cause of pericardial effusion, which is malignant pericardial effusion. How can we know that we have malignant pericardial effusion? If you aspire the fluid, if you withdraw the fluid, partly to relieve the patient and partly for diagnosis, and you found out that the fluid is full of blood cells, or that the fluid is pink in color or even bloody, which indicates that there is an underlying malignancy. I can tell you that I'll not be asking you about the chambers of the heart in the anterior or lateral positions, because this detailed anatomy is a bit too detailed for a human biology curriculum. You just knew them, and it's important, of course, to know the relationships between all the chambers, but I'll not be asking about this. You just have to know that you have a right border, a left border. You shouldn't mix up the right and the left, and you should know that what is towards your left hand is the right border of the heart, and that is what is towards your right hand is the left border of the heart. But it is important to know, this can figure on the test, that the anterior surface of the heart is mostly done by the right ventricle, or is mostly represented by the right ventricle. Because why? This is an important justified question, because during embryonic development, the left ventricle and the left atrium rotate posteriorly. We talked about the pericardium and the importance of the pericardium. Of course, you know the heart chambers and the inner heart anatomy. This is easy. Of course, you might be asked about the function of the valves. I might ask you about the function of the valves in general. So you would say that they are one-door pathways or one direction only pathways that allow flow of blood towards one heart chamber or towards one direction and prevent the backflow of blood. But if I ask you specifically about the atrioventricular valves, which is not the most specific question about the valves because I haven't mentioned the name of the valve, you would say that the atrioventricular valves in general allow passage of blood in general. You wouldn't say oxygenated or deoxygenated because you don't know whether we are talking about the right or the left side. So you would say it would allow the passage of blood in one direction and prevent backward flow of blood. Um, uh, what I've said is a bit general, and it needs more details. So you would more correctly say the atrioventricular valves allow the flow of blood from the upper atria to the lower ventricles during ventricular relaxation and prevent the backflow of blood from the ventricles to the atria during ventricular systole. So you have to specify from where to where and during which phase of the cardiac cycle. Moreover, if I specify more and ask you about the tricuspid valve or the mitral valve, you would specify more and say, for example, in case of the tricuspid valve, allows the passage of deoxygenated blood. In this case, it would be easy for you to deduce the type of blood. You also have to specify that the deoxygenated blood passes from the right atrium to the right ventricle during right ventricular systole, and that it prevents backflow of blood from the right ventricle to the right atrium during systole. The same applies to the mitral valve, but you would say oxygenated instead of deoxygenated, and left atrium and left ventricle instead of right atrium and right ventricle. Concerning the semilunar valves, you would say that they would allow the passage of blood from the ventricles to the large arteries during ventricular systole and prevent backward flow during ventricular diastole. But if I ask about one of the semilunar valves specifically, for example, the aortic valve, then you have to specify the ventricle and the type of blood. So you would say that it allows the passage of oxygenated blood from the left ventricle to the aorta during ventricular systole and prevents backward flow of blood from the aorta to the left ventricle during left ventricular diastole. And meanwhile, you have to also mention the type of the blood. So it's a lot of details if you are explaining the function of a specific valve. Of course, the hemodynamics of the valves, we have mentioned this several times. We have just had a question in the revision, explain the hemodynamics of the heart during systole. So when I say during systole, I mean during ventricular systole. So you have to mention that you have step number 1, the ventricles contract. Step number 2, the pressure inside the ventricular cavities increase. Step number 3, the atrioventricular valves have to close in order to prevent backflow. Step number 4, the semilunar valves have to open in order to allow passage of blood from the ventricles to the corresponding large arteries. Okay, so we have covered all this. Of course, alveolo-capillary exchange is important, just like capillary tissue exchange is important. And of course, you know that they are opposite to each other. But more important is to know the structure, function, adaptation of the capillaries. And all the points that you mentioned about the structure, function, adaptation of the capillaries should serve one purpose or one function, which is diffusion and exchange, because exchange occurs by diffusion. So you have to say, if you don't mention fenestrations are the structures that help exchange, but the rest, the remaining 3, help simple diffusion, even if there is no exchange. So you should mention number 1, a thin wall because they are made of one layer of endothelial cells. You should mention that they do not have a muscle layer, a smooth muscle layer like arteries or veins, and that adds to the thinness of the capillaries. You should mention that they have a large surface area. All these three factors, one layer, a thin one layer of endothelial cells, together with the absence of a smooth muscle layer, together with a large surface area, they all help diffusion. The surface area increases the rate of diffusion. And number four, the presence of fenestrations, which allows or increases the rate of diffusion and meanwhile helps exchange. Now, concerning the heart beats, the control of heartbeats, before talking about control of heartbeats, you should know that how heartbeats are generated. Of course, there is a famous question that talks about the pacemaker of the heart. What is the pacemaker of the heart? And when I say what does the term pacemaker of the heart refer to, it's not enough to say the sinoatrial node, but you should say that it is the part of the specialized bundle of cardiac muscle fibers in the right atrium that controls the heart rate, namely the sinoatrial node. So it's not enough to say that it is a specialized cardiac muscle located in the posterior wall of the right atrium. It's not only, it's not neither it is enough to say that it is the sinoatrial node, but you should say both. And then you can have a question about the properties or the characteristics of the sinoatrial node that helps it be or that allows that allows it to be or that qualifies it to be the pacemaker of the heart. So you would say that it is specialized. How is it specialized? When we say specialized, this means that it is different. It differs from the rest of the myocardial muscles in the fact that it has an unstable membrane potential. This is number one. And you have to explain what unstable membrane potential is. This means that it can generate impulses on its own. And then number two, it can force the whole heart to follow its pace because it has the highest intrinsic rate. This part you usually forget because the atrioventricular node is another spare pacemaker, and it is specialized. It has an unstable membrane potential. But why isn't it the pacemaker of the heart? Because this unstable membrane potential allows it to fire at a rate that is slower than that of the sinoatrial node. And therefore, the one that has the highest intrinsic rate would be the pacemaker of the heart. When does the atrioventricular node become the pacemaker of the heart? When the SA node becomes diseased. But diseased in which sense? Diseased meaning that it slows down the rate. Okay, because there are multiple diseases of the sinoatrial node. If the SA node is ischemic for a reason or another, or diseased for a reason or another, and that disease or disorder results in lowering of the rate of the intrinsic rate of the SA node, then the AV node would be the pacemaker. Okay. But there would be or there could be other pacemakers of the heart without the SA node being diseased, in which case, in cases when we have an ectopic focus in the heart that is firing at a very mad high rate, like for example, firing at 300 beats per minute, of course, it would take over and it would not allow the rate of the SA node to show on the heart. So the SA node may lose its job as a pacemaker of the heart if it slows down, if it becomes diseased and slows down, or even when it is normal and not diseased, but there is a mad pacemaker that appeared in the heart. Okay. How does this occur? How does the, you might be asked a very difficult question, how does the SA node force the heart to go at its pace? Because When the SA node is depolarized, it will depolarize the neighboring areas. And when the neighboring areas are depolarized, they will depolarize the areas after, and therefore the process will continue until all the myocardium, all the atrial muscles are depolarized. And then there is another important question about the spontaneity of the SA node impulses. If the SA node can generate impulses spontaneously, then what's the importance of the autonomic nerve supply to the SA node? What's the importance of the sympathetic and parasympathetic involuntary nerves that supply the SA node? This is just to control the rate. For example, if you're anxious, if you're scared, if you're fighting, if you're flying, then you're tense and there is adrenaline and there is a sympathetic charge all over the body. And this will increase the intrinsic rate of SA node. But within the normal, for example, if you are if the normal rate of the SA node ranges between 60 and 90 beats per minute, then if you are under stress, then your SA node, if you were, for example, having a basal rhythm of 70 beats per minute, and then all of a sudden you have a car crash or you have an accident, just before hitting the car in front of you, your heart will beat very rapidly. This is sinus tachycardia. And by the way, the definition of sinus tachycardia is it is a rapid pulse that arises from the SA node because it is sinus tachycardia, okay, where the pulse is above 90 beats per minute, which is the maximum of the SA node. Some references say 100, it's okay. But what's most important, and maybe we didn't highlight this in the classroom, that you should have say at rest. Because if you are exercising heavily, like some coaches do, and force you to reach a target rapid pulse of 130 or 140, we cannot say that this is sinus tachycardia. This is a physiological response to a severe strenuous exercise. But if you are resting and your sinus rate is more than 90, then this is sinus tachycardia, okay? Now, what's the importance of the atrioventricular node? The atrioventricular node, as we said, is the spare pacemaker for the heart, but the AV node has an important role that is derived from the fact of one important property of the SA node, the slow conduction. So the AV node is adapted to its function because the AV node can generate impulses spontaneously, but it has a slow conduction rate. And so it allows impulses to be conducted from the atria to the ventricles, but with a delay. That delay allows what? That delay is important. Why? Because number one, it allows enough time for the ventricles to fill before they are stimulated. So it allows the diastole to take its time, and therefore the ventricles to fill with blood in order to allow a normal and good cardiac output upon the beginning of the second systolic, upon the second systole. But it also prevents the simultaneous contraction of the atria and ventricles. I think we should say this first. So the delay allows the ventricles to come a bit later than the atria, and therefore it prevents simultaneous contraction. What would happen if there is simultaneous contraction? The ventricle would contract, the atria would contract, the atrioventricular valves, if they, in both cases, whether the atrioventricular valve is open or closed, there would be damage. If it is closed, then the atria wouldn't be able to pump their blood to the ventricles. If it is open, then there would be regurgitation. So it would really be messy, okay? Sometimes when the SA node is not functioning, then the AV node is the pacemaker, and the rhythm that arises from the atrioventricular node is called the AV nodal rhythm, and we will be seeing this on the when discussing the ECG, of course. Of course, you all know what happens to the valves during systole and during diastole. During systole, the atrioventricular valves should be closed, whereas the semi-lunar valves should be open. So whenever the ventricles are contracting, the hemodynamic status is that the AV valves are closed, the semi-lunar valves are open, except at the very beginning of the systole, as we said during the last revision in the classroom, that at the very beginning of systole, we might have a very short momentary phase when both the AV valves and the semi-lunar valves are closed. This is what we call valve coordination. Valve coordination means that when the semi-lunar valves are open, the AV valves should be closed and vice versa. Of course, it is important to know the source of the first heart sound, which is closure of the atrioventricular valves, the source of the second heart sound, which is closure of the semi-lunar valves. And it is important to know that if one valve is stenotic, meaning that it is narrower than normal or that the cross-sectional area is smaller than normal, or if the valve is incompetent, meaning that it does not close properly and it allows regurgitation or backflow of blood, then we would have a murmur. So what is a murmur? A murmur is an abnormal heart sound that is superimposed on the first and second heart sounds. It might be a systolic murmur between S1 and S2, meaning that it occurs during systole, or it might be a diastolic murmur occurring between S2 and the next S1. But whatever type or however, or whatever the cause of the murmur is, whatever the location, of or the timing of the murmur is, the cause is either a stenotic valve or an incompetent valve. I might ask you to justify why does a stenotic valve cause a murmur? I don't care if the murmur is systolic or diastolic, but I care about the presence of a narrow valve and the correlation between being narrow and the occurrence of a murmur. When the valve is narrow, then the blood is flowing through a smaller cross-sectional area. Then there would be no more laminar flows of blood. There will be a turbulent, non-laminar, non-smooth flow of blood, and this turbulence results in the murmur. On the other hand, if the valve is incompetent, then it would allow backflow. Backflow means flow in the opposite direction, flow in the wrong direction. Whatever that wrong direction is it backward, is it downward, is it upward? It all depends upon what the original flow is. In all these conditions, since there is backflow, there would be two flows of blood, two opposite directions of blood, and this, of course, would result in turbulence and the occurrence of murmur. Here, of course, you have to localize yourself and know where systole and diastole are. So as you see, here is systole because it lies between S1 and S2. And here we have diastole because it lies between S2 and the following S1. And of course, it is obvious that diastole is longer. And here we might have a very important justify question, which is justify diastole is longer than, usually longer than systole. But when you have a normal sinus rhythm, in order to allow filling of the ventricles with blood, because the ventricles mostly fill during diastole. Why? Why do they fill mostly during diastole? Because during diastole, the ventricles are relaxed and the ventricular cavity is larger and the ventricular pressure is lower, and all these factors help filling with blood. But there is another reason why diastole should take a longer period of time, because during diastole, not only do the ventricles fill with blood, but also the coronary arteries. And here comes a third question related to the coronary arteries. Why do the coronary arteries fill mainly during diastole? Because the coronary arteries are very small vessels. Not only are they small vessels, but they also lie within the myocardium, within the relatively thick myocardium of the ventricle. So when the ventricles contract, they compress these small blood vessels and do not allow their filling with blood. So they are more at ease during diastole when the thick myocardium is relaxed and the pressure around them is released and they regain their original relatively larger diameter. I'm talking about the coronary arteries. We have talked about the auscultation areas, and concerning the cardiac cycle, I would, as a general rule, I would never ask you in human biology in grade 11 to correlate the phases of the cardiac cycle with the phases of the ECG. I can do this in a classwork, I can do this in a homework sheet, but not in a semester test. So you just have to know that you just have to know that the P wave, for example, which is atrial depolarization, occurs a fraction of a second or a bit before atrial contraction, and that the QRS complex that represents spread of the wave of depolarization over the ventricles occurs just before ventricular contraction. This is all what you have to know about this kind of correlation between ECG waves and the phases of the cardiac cycle. In that drawing of the action potential, you have to know what an action potential is. An action potential means a way in simply, the action potential is the response of the myocardial muscles to an adequate stimulus, and it consists of depolarization and repolarization. So it is essentially an electric response of the myocardium in response to an adequate stimulus. The stimulus should be adequate. The depolarization is due to opening of the sodium channels and inflow of sodium. The repolarization is due to opening of the potassium channels and outflow of potassium. When the cardiac muscle repolarizes, it corrects the electricity, but does not correct the chemical gradient, and therefore the sodium-potassium pump should be acting at the end after repolarization in order to regain or to restore the chemical gradient, because we have now at the end of repolarization an inverted chemical gradient. We have sodium inside and potassium outside. So the sodium-potassium pump will actively pump three sodium ions outwards for 2 potassium ions inwards. By doing this, it achieves 2 goals. Number 1, it returns sodium to the outside and potassium to the inside, meaning that it restores the chemical gradient. And number 2, since it pumps more sodium outwards than more potassium inwards, that it ensures that there will always be more positive charge outside than inside. And then here we have another important, very, very important concept, which is the absolute refractory period. It is the period of time, as you can see, it involves all the depolarization and repolarization time. The absolute refractory period is the period of time when the cardiac muscle is totally irresponsive, however strong the stimulus is, meaning that if you have an adequate stimulus or even a hyper adequate or above adequate stimulus, yet the cardiac muscle would never respond. And this is important in order to prevent rapid heart race. I might ask you about the definition of the absolute refractory period. I might ask you about the significance of the absolute refractory period. The significance is to protect the ventricles against the atria and the ventricles actually against very high rates. I might also ask you about an easier question. We should have mentioned it first, which is the difference between the refractory period in a cardiac muscle and in another skeletal ordinary muscle. Of course, the absolute refractory period in cardiac muscles is much longer than in skeletal muscles. As indicated by what? What's your evidence that it is longer, that we have a plateau in the action potential of the cardiac muscle, but not in the skeletal muscle, of course, because the cardiac muscle cannot afford being tetanized or having sustained contractions or having very rapid heart rates that interfere with filling. And here comes another related question, which is, what's the relation between severe tachycardia and ischemia? Of course, when you have severe tachycardia, even if it is sinus tachycardia, then there is shortening of the cardiac cycle. And when the cardiac cycle shortens, it shortens mainly at the expense of diastole, meaning that it is diastole that is more affected than systole. And if diastole is affected, this simply means the filling time for the coronary arteries with blood, and this is what precipitates ischemia. So don't be amazed if you find that a patient tells you that what triggered his anginal attack was stress or nervousness that resulted in a marked increase in the heart rate, and after this, ischemia started. Of course, the ECG is very important. The overall importance of ECG, of course, is easy because you have experienced it and you have seen how we can use the ECG in order to determine the heart rate, in order to know the type of arrhythmia if present, in order to know the type of ischemia if present, and from the amplitude of the waves and their duration, we can detect some abnormalities of the size and status of the muscles of the heart chambers. Of course, I never ask you about the sites where you put the electrodes or the leads of the ECG. You have to know the normal ECG components, what they stand for, and what's the significance of each. And this, of course, would be a straightforward question. I'll pause for a while and then resume.